Donald T. was born in 1933 to Beeman and Mary Triplett in Forest, Mississippi, USA. But he was an unusual child. He never cried to be with his mother. In fact, showed no affection to anyone. At just 2 years of age, he was able to recite the 23rd Psalm from memory and had an almost manic obsession with spinning objects. But he could also fly into a temper tantrum if his daily routine was changed and wouldn't feed himself. In desperation, when he was just 3 years of age, his parents agreed to him being institutionalised. But they had a change of heart and retrieved him 1 year later. The family moved to Baltimore, where they took him to see renowned psychiatrist Dr. Leo Connor. In 1938, at 5 years of age, Dr. Connor names Donald T. as Case 1, the first person to be diagnosed with autism. Temple Grandin is one of the most well-known autistics in the world today. It's estimated that around 1% of children today are somewhere on the autistic spectrum.
Like when I was 3, I looked really severe.
A number of historic figures are suspected of being autistic, including Isaac Newton and arguably Albert Einstein and Emily Dickinson. Today, numerous famous people have acknowledged they fall somewhere on the autism spectrum, including entrepreneur Elon Musk, actor Dan Aykroyd, Nobel laureate for physiology in 1983 Barbara McClintock, and popular singer Susan Boyle.
Look at people like Thomas Edison,
Yeah.
Nikola Tesla, the inventor of the power plant. Michelangelo was probably autistic. Now, what enabled these individuals to do something good, like great art or invent all kinds of things? One of the things is early exposure to the profession. Michelangelo was exposed to great art in all the churches, and he was exposed to the stone cutting tools that he'd need to make his sculptures with. Thomas Edison had a mentor who taught him how to be a telegraph operator.
So what does it mean to be diagnosed as autistic? The Diagnostic and Statistical Manual of Mental Disorders, the DSM, presents the diagnostic criteria for autism spectrum disorder, which includes deficits in social communication and interaction, restrictive, repetitive patterns of behaviour, symptoms that must present in early development although may not manifest until later in life, and symptoms that cause clinically significant impairment of social or employment capacity. An autistic person may or may not have an intellectual or speech deficit. How these symptoms are measured and manifest can vary widely between individuals and conditions.
So there's a set diagnostic criteria for autism spectrum disorder, although we tend to call it autism now because many people would say it's not a disorder. So we have differences in social communication, so the way you interact with somebody on a social level, and then the restricted and repetitive behaviours and interests. So that includes sensory challenges, specialised interests, and an insistence on sameness. Now within each of those, there's so many different ways that each criteria can present based on someone's age, their ability, and them as a person. There's no one checklist you can use to have each individual thing to look for. You need to understand the criteria, understand the person and the environment they're in, and appreciate that the different ways autism can present differently in different people, in different ages.
Not only do I work with clients on the autism spectrum or autistic clients, but I also
have been formally identified as autistic myself in my mid to late 30s, diagnosed according to the DSM-5. So there's the two sections, the top one, which is the sort of social communicative part, and then the second or bottom section, which is sort of your, well, I don't like a lot of the terminology, but it's the like restricted repetitive behaviour, sensory kind of, deep interest part.
There are also neurobiological and genetic indicators for autism, but these too can be inconsistent.
There's no research to suggest that there's any one definitive sort of difference in the autistic brain. So actually the research that's out there is highly variable. Some research, for example, might show that some individuals on the autism spectrum might have an enlarged or bigger volume in their hippocampus, which is involved in the formation of our memories. Then there's some other research that shows that particularly children and adolescents on the autism spectrum might have a larger amygdala. So that's sort of the area of our brain that controls our experience of emotion and also plays a role in forming our emotional memories. So, let's say we've got a phobia of heights, that making that association between feeling fearful and there being at a great height, for example. So we know that there can be differences there, but then there's research that has also found that some individuals on the autism spectrum might actually have a smaller amygdala too. One of the most consistent findings we see is that there's differences in the connectivity of what we call the default mode network of the brain. That's essentially implicated in our ability to daydream and think of the future, but also in terms of theory of mind, so perspective taking, understanding another person's point of view.
Although described as a disorder on a spectrum, autistic spectrum disorder, or ASD, is a description that is not agreeable to everyone.
And I guess the first thing to bear in mind is that when there are the challenges and the difficulties, it's not because autism is wrong. It's not because we need to, cure the autism. It's because I guess there's a certain mismatch between the person's particular profile and maybe the expectations day to day, or societal expectations or social expectations.
One of the people on the spectrum that we spoke to talked about how a person on the spectrum doesn't want to be fixed or have their autism taken away, but they want to learn more about how to function in a neurotypical world as a neurodiverse individual.
There's an increasing recognition that not everybody sees autism as a negative experience. There's a neurodiversity movement which says that actually brains are all made in different ways, and actually if we celebrate diversity, we can accommodate diversity and help people to be the best version of themselves.
The terms neurodiverse and neurotypical are developments in the language of how we describe the way brains are different, and people with different brains have different ways of engaging with the world.
Now, there are definitely people that agree more or less with the neurodiversity model, but I think we need to embrace it and work with it and talk about autism as an experience, a whole body experience, a whole life experience, rather than a disorder that we need to cure or treat. And once we do that, we can appreciate that there's things that we can do from a community perspective, rather than just expecting the person himself to change and fit into a neurotypical world.
There's a very short chapter that I wrote for a online magazine called Autism Spectrum, or it's funded by the Simons Foundation. And they asked me to write about what I was doing. And I started off by really writing that the families of autistic individuals have gotten a raw deal from the academic and the research community. Because the real problems with autism from the family's perspective is this whole issue of behavioral state regulation. And all the research money went into genetics, went into pharmaceuticals, went into a model that there's something damaged with the individual and it can be fixed, or we can find that damage and then we can learn how to fix it, as opposed to looking at the proximal disruption, which is behavioral state regulation. So if you could reduce, or let's say mitigate, state regulation disorders, tantrums, shutdowns, all the behaviors that the parents, and the teachers and all the caregivers have great difficulty dealing with. If you could deal with that, reduce the frequency, and perhaps even just totally remove it in some cases, what would the quality of life be for those who carry that diagnosis and their caregivers and their family? It would become much better.
Being able to regulate or reduce disruptive and reactive behaviours is an important goal. But self-regulation can be a two-edged sword.
Some kids that end up with a diagnosis on the autism spectrum, you see those signs very young. You might see differences in eye contact. You might see that they're not gesturing. We routinely, through development, toddlers will sort of start pointing at items to request them before they can speak. But some individuals on the autism spectrum, they might not gesture at all. So that's one of those hallmark signs we might see, for example. But then we do see a group of individuals on the autism spectrum make it all the way through to adolescence before they present for a diagnostic assessment. In these individuals, what we tend to see is that they're sort of able to mask or camouflage their difficulties that they're having in those social communication environments up until a point where they just can't anymore. And that social demand is just a bit above where they can sort of handle. Yeah.
So camouflaging is basically an umbrella term that has three different categories underneath. The first one is assimilation. So basically assimilation is learning to use strategies to try and fit into uncomfortable social situations. So this might include things like forcing eye contact. It could even include things like sitting in a group but not actually contributing to that group, but you just act as you're part of that group. So another term underneath the camouflaging is compensation. So compensation strategies is to do with strategies to compensate for social difficulties and to try and fit into the social world. So things like this might be to practice body language or facial movements in the mirror. It could also be trying to dress a certain way. And then the third category is masking. So masking is one of these important categories and is one of the main reasons why women go undetected. And this is due to the fact that they try their best to mask their neurodiverse or autistic traits to appear as neurotypical as possible. So doing this, you could be something like hiding stims. So instead of having overt stims that you would have in the privacy of your own home, you'd actually convert those sort of stims to something that isn't overt, like hair twirling or leg bouncing, something that doesn't bring attention. Another possibility is refusing to talk about certain subjects to avoid info dumping. So those sort of strategies can be used and employed to try and, appear as neurotypical as possible.
The recent research has linked camouflaging, which is hiding our authentic autistic selves, has linked that to suicidality, poor mental health. Yeah. So even though that tends to be what therapists might be kind of drawn to do, like, therapists might meet an autistic person, think, okay, if I can teach this person to appear more normal, again, whatever that is, then that will be better for their long-term mental health. Actually, we know it's the opposite, because the resources that go into hiding our authentic selves, like just the cognitive resource, the not being authentic, really does take a toll long term on our mental health.
So camouflaging and masking can be used to hide autistic behaviours, but that can create stress, anxiety, depression, and even suicidal thoughts. At the same time, anxiety and depression can affect everyone, So it's not always just about being autistic.
It can be difficult for mental health practitioners to differentiate between the characteristics of autism and some of the mental health conditions that might co-occur with autism. So this is called diagnostic overshadowing. So this is when a practitioner might misattribute some of the symptoms of one condition to another condition.
One of the main aspects in, I guess, with misconceptions in autism is that autism automatically comes along with social anxiety disorder. And in fact, that's not actually the case. Autism and social anxiety disorder are two completely different things. So when you're looking at social anxiety disorder, you're looking at things like fear of judgment, fear of negative evaluation, of upsetting others, things like that. So it's more around a social context. But when you're looking at autistic traits, or what we call autism-specific anxiety, then you're looking at characteristics that are specific to the core traits of autism. So sensory difficulties, or social communication difficulties, so not knowing what to say. So not necessarily that fear of negative evaluation, but it's more to do with the core traits of autism.
And so it is very important for therapists to understand autism and adapt to the individual nature of their experience. This is also important for teachers who will also come across children on the spectrum. We simply need to know how to interact effectively.
I'm the project consultant on the Autism and Mental Health team for Autism Queensland. I'm a person on the spectrum. I like to identify as an autistic person on the spectrum, or autistic person. I'm currently studying psychology in my honours year. Yeah, so I've had a lot of experiences with multiple different psychologists and multiple different specialists actually. Some of them don't know a lot. I've had some fairly negative experiences with a couple. I've also had some positive experiences. My current psychologist and I have clicked. It's fantastic, a great experience there. One of my previous psychologists I've had, she was a lovely person, and while she understood autism in general, it was that sort of, we weren't able to connect in that sort of way, and I think it could be helpful to build training around that sort of ability to build rapport in those circumstances.
You know, the thing is that as psychologists, most of us are verbal thinkers.
Yeah.
And that does not work. So when we work with an autistic client, if we just try to amplify our verbal communication, it's like talking louder to someone who's hard of hearing. It doesn't hit the spot.
Yeah.
And instead, we have to know what kind of thinker they are. And Tibble can talk more about this in a second, but we have to know that it's probably not going to be verbal. It's probably going to be visual or visual spatial. And we have to use tools that reflect that in the therapy. And I don't think therapists are being trained to do that.
Well, I'm an extreme visual thinker, and that's what's called an object visualizer. In fact, I discuss that in detail in my book, The Autistic Brain. Then you have your visual spatial. This is your more mathematical mind. This is the kid that'll be into music, computer programming, mathematics. Those things tend to go together. And the object visualizer and the visual spatial are two different kinds of thinking. And the research is very, very clear on that.
Autistic brains often are sort of what we call monotropic. So have a tendency to focus on sort of, one or two things at a time, as compared to polytropic minds, which focus on a larger number of, topics or stimuli, or whatever word we want to use. And so a monotropic mind just wants to dive into maybe one topic very thoroughly for quite a period of time. Now, if we think about the way that school settings are set up, there's a lot of switching between subjects, even during single lessons, but also over the course of the day. You know, you go to English for an hour and then you're switching to maths. And so that's set up more for a polytropic kind of mind than a monotropic mind. So often autistic people haven't had a chance to really see what their minds can do when they're kind of allowed to dive into a topic for a period of time and really soak up that information.
I looked a lot at how hand gestures can actually impact communication and learning. And what's really interesting is there's this sort of strongly held belief that individuals on the autism spectrum have difficulties using and also interpreting gesture. But there's actually not that much research that actually suggests that that is definitely the case. So what I actually found in my PhD is that not only does observing another person's gestures, like a teacher's or a parent's, benefit learning in children that aren't on the autism spectrum, it actually showed that watching someone else's gestures can benefit memory and recall of stories or narratives in children on the autism spectrum as well.
It is the extent of variation across the spectrum that can confuse even the well-intentioned.
Then they kind of go into 3 groups: so fully verbal, no intellectual impairment, then you have a mid-range group, and then you have some that are nonverbal.
A common problematic movement symptom of autism is called stimming, which is a repetitive or unusual movement or noise that helps some autistic children and teenagers manage emotions and cope with overwhelming situations. Stimming can be movements like flapping hands or snapping fingers, perhaps bouncing or twirling or pulling hair. It can also be repeating words or phrases or sounds.
And do things like stimming, which is, I guess, things like hand flapping and moving around, in ways that feel quite natural to us as autistic people, but might appear quite odd to other people.
A good therapist will make allowance for these needs.
To adapt to my autistic traits, she makes sure that she asks whether the temperature in the room is correct, whether or not I'm feeling comfortable, or whether I need something to sit on that's more comfortable. Sometimes the room may change, and changing of rooms can actually cause anxiety because it's not predictable. So she'll give me the heads up on whether the room is going to be different or not. Quite often she'll check in on whether or not I need stimming toys, or I need to do something with my hands, because that's one of the things that happens when I get anxious. I tend to use my hands a lot and stim a bit.
But this form of consideration is a relatively new practice.
I was involved with researching autism from, I guess, the late 1980s, and the view was to break the corridor or the boundary. In a sense, therapists were extremely aggressive with autistic kids, in a sense, the feeling that they had to break through. So there'd be, at times anger, or you making sure the child understood that there's going to be punishment if they blocked, without understanding that this is not a disinterest. This was because sound was hurtful to them. When they're locked into this state of defense, and a lot of autistic individuals are like this and like this, they're telling you that they are in a state of threat. And so the behavioral model was get those hands away from the ears, engage, give you more reward. It's disrespectful of the physiology of that individual. Yet if you look at them, even when you're trying to shape the behavior, they're in great states of fear. Some of them will even be shaking. And the issue is you have to respect their bodily response and the state they're in.
The other thing was some of the sound sensitivity. That can often be helped by letting the kid control it. Also, like a car horn, let them beep the car horn, turn the hairdryer on and off. Some kids hate automatic doors. Well, go there when the store's not busy and let the kid make the doors open and close. where they control the sensory thing that they don't like. That sometimes helps to desensitize it. There was another case where they were terrified of the buzzer on the scoreboard down in the gymnasium. So they took him down there when nobody was there and let him push the button repeatedly. Then he started tapping out tunes on it.
When we're thinking about how to support someone, it's about how do we create the best setting for that person to be the best version of themselves, to give their best, to achieve their best. The easiest thing to change is the environment. If you can change lighting, sound, or how many people are in a setting, and that means someone is able to achieve their best, that's a simple modification to accommodate someone's preference. Now, if we think outside of neurodiversity, we all have our houses set up the way we feel most comfortable. If we work at home, we have an office set up to be most comfortable. If we're willing to do that for ourselves, why aren't we willing to do that for someone who's neurodiverse?
Stephen Porges saw something more in these sensitivities, especially in relation to his polyvagal theory, where the muscles of the inner ear and the vagus nerve are connected and responsive. Sound is more than just annoying. It can also be soothing.
So this goes now into the acoustic intervention. And the acoustic intervention is functionally, you can think of it as an acoustic vagal nerve stimulator. You can think of it as a neuromodulator. It gets at the system by giving it cues of safety, and it starts to turn off threat reactions. So what it does, if we look at how the mother's voice works, there's an intonation, there's a melody or melodic features. And if the melodic features are there, the baby calms down. We've just completed a study basically using there's a paradigm called the still face. It was developed by Edtronic. Basically, it has 3 segments. They're 2 or 3 minutes, 2 minutes each, in which the mother is playing with the baby. The mother then just freezes her face, and then 2 minutes later re-engages the baby. And what happens is that the still face, or the flatness, removes the interaction, the cues of safety that the baby was looking for. And babies will, at 6 to 9 months, will reach out to the mother, try to say, "Are you okay?" literally engaging, and then may go into tantrum. The interesting part is we measured the baby's heart rate and we looked at the acoustic characteristics of the mother's voice. If the mother's voice had more prosody, more positive affect in the voice, more melody, more intonation, the baby's heart rates went down. If the mother had less of that, the baby's heart rates went up. So we could actually see how effective the mother was in calming their baby. And in a sense, the mothers are doing the same thing. They're talking to their babies and they're trying to calm them. But the baby's nervous system is making a discrimination. And in polyvagal theory, we call that neuroception, where the nervous system is evaluating risk in the environment through a variety of cues. And one of the cues is intonation of voice. It's not a cognitive perception. It's not a decision making. It's built into our DNA, that intonation of voice calms us. Look at a mother with a baby. Look at an adult male with their puppy. It will be the same thing. We will talk to the childlike individuals with these intonations, and they will calm down. So we have a toolkit that we know intuitively that will turn off threat reactions.
After many years of careful work, he has developed the Safe and Sound Protocol.
And the interventions have to be tailored to change state. Now, the Safe and Sound Protocol, which is this acoustic intervention, I view it as a stealth intervention because it doesn't require any conscious interpretation. It just requires a passive pathway of listening. And this is, in a sense, it's not hard. You're not giving them a task to do other than to listen. And interestingly, many will just sit still and listen and get pulled right into the modulations. So what it does is it does a computer alteration with various filters of the acoustic music. So it is literally a neural exercise of the middle ear muscles. So in the middle ear, you have muscles, but those muscles are regulated by a branch of the facial nerve that's linked to the nerve regulating the orbicularis oculi, the upper part of your face. So when they start to listen, they start getting this engaged look.
That's exactly what I'm going to do.
And that nerve in the brainstem, the area where it controls the middle ear muscles and the upper part of the face, is linked to the nerve controlling the vagal regulation of your heart. So when this system starts to work, it starts to calm you down. And that system is linked to the vagal and pharyngeal regulation of the larynx and the pharynx, which are actually vagal nerves. So what you're doing is, by piping in these modulated sounds, you're getting into a brainstem area that creates an integrated social engagement system that includes ingestion. So when you look at the world of autism, of course, their selective eating is one of the major features. What happens after the safe and sound protocol? They start exploring food.
Innovative ideas like the Safe and Sound Protocol are being matched by education and awareness programs for therapists and other professionals. Autism Queensland has launched a project to help community mental health practitioners create autism-friendly services.
So we developed training workshops for all sorts of mental health practitioners and general practitioners as well, to help them to understand autism, what it looks like on paper, but what it also looks like behind the scenes or in the individuals that might come to see you as part of therapy. So that involves the stories of people on the spectrum.
Trying to adapt to the person's learning style, using multiple modes of presentation and how to explain the information, and also trying to adapt to those executive function difficulties as well that they may have. So like downloading things or sending multiple text reminders before the appointment comes, even having a what will happen story. Those things would be very, very beneficial for someone on the autism spectrum.
So that might include an understanding that someone's very sensitive to hearing or unnatural smells. So in the therapy room, the therapist's perfume might have a scent that makes it difficult for the person on the spectrum to concentrate. So we want to create an environment in therapy where the client feels comfortable to let the therapist know that. So there might be other modifications that we can make in the therapy room as well. It might be to do with lighting, noise, having objects there that have different tactile experiences for the client. And then outside of therapy, we might help the client understand some modifications like wearing noise-cancelling headphones in a busy area, or avoiding a shopping centre at certain times when they know there's lots of people there.
And at the Autism Centre of Excellence at Griffith University.
And you make sure that we are listening to the aims of the person and the client rather than putting our neurotypical aims on. Then, of course, once you work out what you're going to work on and what your goals are, we can't assume that someone is going to fit into the models which are based on neurotypical CBT models of anxiety, for example. There is a lot of research and literature now on autism-specific models of mental health. It's your role as a psychologist to go and read about that and learn about it. If you're able, discuss it with your client and say, we know that sensory has a role here. What do you think about how sensory interacts with your anxiety? Listen and learn, incorporate that, and be willing to work together in a partnership. So you are learning just as much about the autistic experience as they're learning skills about psychology and mental health and ways to reduce mental health challenges.
Adapting to needs and to learning styles and thinking styles, all with the purpose of enabling positive skills and natural capacities of the individual. The question is the same for all people. What are the ways we can discover and express our potential and explore our possibilities?
I think you want to make sure that you're looking for strengths intentionally. not just the fallback of looking at the deficits. I think in an evaluation, you want to make sure that you're giving equal time to strengths. I think that you want to give the child an opportunity to show you those, and that means being a little more creative than just giving the same testing administration to every child that comes through the door. You need information ahead of time in order to customize an evaluation. You need information from the parents. You need information. Sometimes home videos are full of good things that then you can follow up on and get more information. You need to know a little bit about the associated conditions, both psychiatric and medical, because you don't want to miss those, or you don't want to misattribute something to autism that's not really autism.
I get asked all the time how I got interested in the cattle industry, because I came from a non-cattle background. I was exposed to it as a teenager. Yeah. And I think one of the worst things the schools have done is taking out all the hands-on classes, because they expose you to careers like music, theater, art, sewing, woodworking, cooking, welding, building things. And we actually have a shortage of high-end skilled trades right now for designing equipment, building factories, just doing all kinds of things. And the big problem I'm seeing, too many parents getting so much into the medical model that you might have a 16-year-old teenager, really smart, who has never gone shopping or gone on the bus. This is ridiculous.
We know the biggest predictor of success vocationally is having had a job during high school, a real paying job, not a volunteer job. Now, if you can't find one, then a volunteer is great. But if you get a real paying job and not in your family business, but someone who's a stranger who you have to learn to show up on time, you have to learn some skills, you have to learn to accept feedback, those very real world things that will then transfer. Research shows that's the biggest predictor.
No one is suggesting that autism does not create a number of challenges. Learning more about how to work and engage with people on the spectrum is an important early step. It is equally important to understand the difficulties that can be faced, which include other issues with physical and mental health.
So when we're working with clients on the autism spectrum, we have to understand that mental health can present differently. So what we see in children is that anxiety tends to present behaviourally. This means when you're looking for signs or indicators of anxiety, don't look for a racing heart or sweaty palms. Because of interoception and alexithymia difficulties in autism, you might not have that as a symptom that the person recognises.
Right. So alexithymia is essentially a word to describe the decreased or the inability to express emotions through language. It also includes things like difficulty with understanding emotions, sometimes as well internalized emotions. So this can actually cause a bit of a problem when it comes to mental health diagnosis. So if someone can't exactly say if they're sad or they're feeling apathetic or they're feeling depressed, then trying to diagnose someone with depression or anxiety might actually prove quite difficult. But you'll find that some people with alexithymia may actually have different ways to express their emotions. So, for example, someone who's depressed might explain it as a black cloud following them. Or we all probably know about the Black Dog Institute. Some people explain it as the black dog. Other people might explain it as a weight on their shoulders. So yeah, creating a dictionary of abstract ideas might help with the diagnostic journey along to finding what the correct diagnosis is for a mental health condition. It also might be helpful for someone to try and express their emotions through different creative means. So things like song lyrics or colours or even poetry can actually help individuals on the spectrum to express how they feel without actually using that emotional language.
It's really important that our clients are receiving support and treatment for other co-occurring conditions. So that might be things like epilepsy or gastrointestinal difficulties. There might be comorbid learning disabilities as well, or language difficulties. So when we have a multidisciplinary team involved for a person on the spectrum, that's when they have the most success.
One thing that the research has shown very clearly is that gastrointestinal issues are often associated with autism. A lot of times. I was just at an autism conference live just very recently, and there was a little boy that was pulling out his hair and doing real severe self-abuse. And I said, the first thing you've got to rule out is a hidden, painful medical problem. Maybe he has an ear infection, a sinus infection, a toothache, okay, since he's attacking his head, and acid reflux problems, and pain from acid reflux is common. I talked to one family, because my mind thinks in specific examples, where in one of my other books I had recommended using acid reflux medicine, and I had a family come to me and you just saved us. Simple, over-the-counter drug, and raise the head up of the bed a little bit to keep the acid in the stomach. All these behavior problems stopped. So you always have to rule out a medical issue that has nothing to do with autism, that causes pain and discomfort, constipation, diarrhea.
So most people will say, well, I have a headache, or I have a stomach ache, or I have palpitations, I can't go to that party. But that's at the extreme. We have to understand that often, especially kids at school, where they'll talk about their gut hurts, and what they're really telling you, that they're in a state of fear to go to school. Mm-hmm. And the issue is, why are they in a state of fear? And many of them feel that they may be bullied or they may be injured. They're telling you a truthful, valid reflection of their own experience. So what we want to really do with a polyvagal perspective is to honor and respect the individual's response.
We've got a significant proportion of people on the autism spectrum have a co-occurring intellectual disability, and it could be mild, moderate, severe or profound. And when you combine these diagnoses together, you have a sort of greater impact of challenges. We also have about 40% of people on the autism spectrum with a diagnosis of anxiety. So 4 out of 10 people will have clinical levels of anxiety, and we think about 8 out of 10 will have significant anxiety, clinical or non-clinical. When you combine the autism and the anxiety, you end up with these greater challenges, more significant autism characteristics because of the anxiety, more significant anxiety because of the autism, and they interact and sort of multiply. Rather than thinking about autism and anxiety, we say autism with anxiety, because they interact and they create a challenge.
There are also co-occurring conditions that are surprising and extraordinary and can astound the average neurotypical. Another of Donald T's extraordinary mental feats was to be able to calculate the number of bricks in the wall of a school auditorium after just glancing at it. But the mental capacities of autistics have contributed to changing the world.
You'll see a lot of individuals on the autism spectrum with these sort of savant skills, like, you think of like Rain Man and those sorts of examples. But when I see individuals on the spectrum, I see so many different strengths. And one of my favorite things to do clinically is actually highlight these, whether they're personality traits like honesty, loyalty. Those are huge things I see in individuals on the spectrum.
In fact, we did some research last year asking young children, what are your strengths and what are you absolutely best at? And what was really lovely about that was that many younger children, so primary school age children, were able to tell us about the strengths they thought their autism brings, including that it makes them a good friend and fun person to be around, or it makes them unique.
I think one of the strengths, and I love that working with autistic people as well, is just that, we just have this mutual honesty in the sessions. Yeah. That works really, really beautifully. And it can be really confusing as an autistic person when other people aren't brutally honest like that. Because that's our preferred communication style. And when people are skirting around something or, not saying what they mean, it's like, just say it. And I think part of that is because often the facts feel more important than social niceties.
I think one of the things that I have appreciated about Temple, and I've appreciated about so many of my autistic clients, is I know exactly where I stand. I know what Temple thinks. She tells me bluntly, there are no games being played. We're concentrating on facts. She suffers no fools and obviously is brilliant. And that's rare. That is one of many. Those are several of many qualities of autistic folks that are so underappreciated.
To be appreciated and valued for our individual qualities and to be warmly included into the social fabric seem to be the fundamental qualities of an advanced society. But understanding and appreciating the diversity of mindscapes that exist in human beings is an ongoing project. Whole swathes of our populations are expressions of neurodiversity, as well as social and cultural diversity. Our species has shown that it is by utilising what is extraordinary within us and amongst us that has been at the core of human development.
And when it comes to a clinical setting, it's really about learning from the autistic community and the number of autistic therapists that are around as well, particularly if you're not autistic yourself as a therapist and you're working with autistic people, then just learning as much as you can from the autistic community about what it's like to have lived experience of autism, rather than learning from the textbooks, which are a very kind of outside-in look at autism.
We're seeing workplaces proactively recruit people on the autism spectrum because of their strengths and their skills. And that's not just IT jobs. We're seeing the Queensland Department of Education had a whole recruitment drive for neurodiverse applicants because they can bring so many skills and strengths to a team and make that a collective strength.
I'm seeing individual cases, like this person that sells equipment all over the world, and what saved him was one welding class. And then I'm seeing somebody that's very severe, and then I've met Tito, who's nonverbal, who types independently. I'm seeing him. He's very different from the person that runs a metal fabrication company. You see, it's specific.
When I was in Chicago, a psychologist from another medical school brought his child into my laboratory for the intervention. The child was, quote, autistic, severe. He had a testable IQ of 70 at that time. He goes through the 5 1-hour sequence and is doing really well. The father calls me and he's pestering me for more. I said, no, it's a research project. That's all I can do. And then I don't hear from him. And a year or so later, I decide I would contact him because I wanted to create a board because I had created a program within the school for autism. I want some external advisory. And he said, my son's no longer autistic. He tests with 140 IQ now.
You know, if you think about how society has advanced, I would venture to say the great majority of the time, it's been on the backs of someone who is on the spectrum. Because those are folks who have brains that are wired in a way that they can let go of a lot of the other normal things that take up our time. They don't care about that so much. And they can persevere or get quote unquote fixated on special interests and stay with that and focus. And often the ADHD is going along with it and helping. And they also have this out-of-the-box thinking. So they don't just take a baby step in their thinking, they take a leap of faith because they don't care. And suddenly you have someone like Elon Musk taking, 4 civilians into space.